Chest x-ray, can you name the 12 signs? Maybe when I was doing my board exam I could, but I can't do it now. And a third of are normal to the untrained eye. That's the average emergency medicine physician. So, you know, the classic ones we talk about, loss of aortic knob, the calcium sign, so all these signs. I'm not going to order a chest x-ray to risk stratify a patient like that. So what do we do then? Well, imaging is where we have to go, right? So we do, we start with the CT. Everybody's, you know, gets a CT angio. Now, you don't angio just part of the aorta, right? The aorta is big, right? So whenever we order acute aortic syndrome, yeah, but Joe, I'm only worried about thoracic. No. They're getting the whole aorta. So we have a special sort of protocol for the whole aorta, number one. Number two, who does ECG-gated CT angios? And I'll tell you why that might be important. Has anybody heard of it or do it? Did they do protocolize that? So the whole idea here is that with each heartbeat, you get a bit of motion artifact that can mess up your CT angio. And what they do is they time the contrast load and the imaging to a certain part of the ECG where the heart is the most quote-unquote dormant. And the evidence actually, it makes sense, but the evidence is not very good, by the way, that it's any better. But I'm just telling you that if you, like in a quaternary center, they will do a CT, ECG-gated CT. And then if there's a relative contraindication, which I don't know what there would be, MRI, transesophageal echo, if you know what you're doing, very good as well. And then transthoracic, I told you that with very limited learning, you can actually get pretty good at looking at aortic root and stuff like that. I would not use it to rule out, but you can definitely rule in the transthoracic